The agenda for this afternoon, it's 12:50, and we have about, it was supposed to be a 45-minute presentation, but I think we can do it in about 35 minutes. And then we'll be on time for the afternoon sessions that'll start at 1:30, the panel, which I'll have a slide on how we're going to do those breakout panels. So enjoy your lunch and enjoy this talk, and if you need to sleep, now would be a good time during our talk. So we'll have a little siesta time, put on soft music. My name is Kerry Kuehl. I'm a professor of medicine at Oregon Health and Science University. Diane Elliot, who is, we're co-partnering this talk, is also a professor of medicine at Oregon Health Science University. And Diane hired me as the exercise physiologist in 1983. So everything I am or could ever be is because of Diane Elliot. She actually was my mentor during my K training grant, and really has, her and Lynn Goldberg, our other partner, really did mentor me and bring me along. So what we want to present today, or for the next half hour, is really a project that got funded at the same time of John Violente's program in 1999. Diane Elliot applied and got a grant for firefighters, and I'll talk about how we got funded on that. But we're gonna show you an evolution of a intervention that was quite successful, a team-based intervention, and then taking that from science to service. Our experience of having 2 additional grants for a dissemination and translation of a program. And now the culmination is going to be an STTR phase 2, where she's going to digitize this entire curriculum into an easily disseminatable and usable app for this wellness program, this health and safety program. So with that, I want to thank the Oregon Department of Corrections for partnering with us on our research. Also, the Oregon Institute of Occupational Health Science, Dr. Steve Shea and Kane Anger, our Oregon Healthy Workforce Center, and then we'd like to thank CPH New as well, and then the FLAME study. The FLAME study was funded by the National Institute of Arthritis and Musculoskeletal, the NIH branch for arthritis and musculoskeletal health. NCI funded us the second 5 years, the NINR, and then NCAT. So the objectives of this next half hour, number one, we'll describe the FLAME program. It's a team-centered, peer-led program, a total worker health program, health protection, and health promotion program and its outcomes. And then really to draw parallels between, can we translate some of the information we've learned from fire and my police SHIELD study, which is a current NIOSH-funded study on law enforcement officers, and can we translate that into corrections? We're going to describe the findings concerning the program adoption and implementation, and then again share our lessons about program dissemination. So we've talked about some safety issues today, and Jeff this afternoon is going to be talking more about safety and corrections, but I'm a health promotion. We're health promotion. We've learned a little bit about safety, but you know, why promote health behavior? Why promote healthy lifestyles? Because unfortunately, what we die from, 70% of our healthcare costs are due to lifestyle. 1 in 5 Americans still smoke. 3 out of 4 eat an unhealthy diet. 4 out of 5 do not exercise. So only 20% of Americans exercise enough to change and alter chronic disease. 7 out of 10, unfortunately, are overweight, a third obese, and a third overweight, which it's even more startling when I show you the statistics from corrections, what the overweight is there. Only 8% are at ideal body weight among our cohort of corrections officers. And at least 5 to 10 are sleep deprived. Diane and I wrote, the IAFC, International Association of Fire Chiefs, asked us to write a report, and the United States Fire USFA asked us to write a report on the effects of sleep deprivation on EMS. So I think it's one of the best reports on the effects of sleep deprivation on firefighter and EMS. We present the acute and chronic effects of sleep-related illness, sleep disorder, and then we provide mitigation strategies and our FLAME program has those mitigation strategies in there. So a significant amount of illness, acute and chronic illness, come from sleep deprivation in this country. FLAME was funded in 1999, as I said, the same time as John's BCOP study. And the RFA went out and it said, we want you to choose a high-risk population and do at least two, if not three, behavior change interventions on that high-risk population. And they were targeting smoking, exercise, diet, obesity, injury, illness. So actually we chose firefighters and got completely rejected on the first. And they said, firefighters are already healthy. Why are you choosing firefighters? You know, it's not a high-risk population. So previously, we demonstrated that among high school athletes, team-based, peer-led behavior change programs work. So among high school football players, among middle school and female high school athletes, Dr. Elliot's Athena program, Dr. Goldberg's Atlas program really showed improved nutrition, exercise, health behaviors, reduced drug use. It was durable. 3 years after the high school female athletes graduated from high school, they were 50% less likely to use drug use. They had less eating disorders, less supplement use. That was just from a 1-year intervention. So team-based programs worked. Could we take that? Could we extend it into the workplace? Could we take this 12-week, 1-hour curriculum, 30 minutes once a week, 12-week program, team-based, peer-led, and transfer that into the real world? So we thought, who is a natural team-based setting in the workplace? Firefighters. Eat together, shop together, sleep together, live together. Well, not sleep together. Sleep close. And now there's separate rooms for male and female, but when we started, there wasn't separate rooms for male and female. So the point is they live together. They're a family. So we thought, let's extend this team-based program that worked, this peer-led team-based program that worked, and let's extend it into the workplace. But then they still said, firefighters they're not high risk. But we showed that indeed they were high risk from our own research, but also from national data, that more than 65% have greater than 3 cardiac risk factors and 40% have greater than 4 cardiac risk factors. They have the highest on-the-job heart attack rate of any occupation. What they die from on the job is heart attack. And it's not so much the 20, 30-year-olds, they all look super fit. It's as you get into your 40s, and from this previous picture do I have, every fire station have lazy boys in them. And that's where they sleep and nap. They get a couple calls a day. So really the 40, 50-year-olds, it's not an active lifestyle. So the good news is we got funded. We also know that they have about 8 to 9 times the rate of injury rates as private industry. And those injury rates occur despite fires. Most fires occur in the afternoon, but that's not when firefighter injuries occur. You'd think, right? The fire ground, injuries, fighting a fire, holding all that gear, slipping around, that's not when the injuries occur. They happen when they get a call at 1 in the morning and they fall down the trip around, they stumble around. So sleep deprivation, waking up to that alarm and moving. So injuries occur between midnight and 6 a.m., but most fires occur in the afternoon. So we know that sleep and longer hours have an effect on injuries, sleep deprivation. So here's the FLAME study. This was the original study. We had 678 firefighters originally volunteer to participate in the study, and they were randomized by station. So we didn't randomize by firefighter. We had 36 fire stations in Portland. 12 stations they all got tested. They all got comprehensive testing, EKG, physician comprehensive testing, VO2 max, blood work. They all got testing and their results. That's the control group. And then 12 of the stations, or over 250, got one-on-one coaching, and then 12 fire stations, or approximately 250 firefighters, got our team-based wellness program, where once a week for 60 minutes for 12 weeks they went through our intervention. So as I said, they all got annual assessment, and we followed them for 4 additional years after the 2-year study, and body composition survey. This is the way the team-based curriculum looks like. So this is, there's a team leader manual, and amazingly, if I gave this to Dr. Panett right now, she could lead her table. You could, I'm guaranteed. This is a scripted curriculum. You could lead your table without knowing anything about in this hour. The activities are nutrition, exercise, stress, supplements, what kind of protein, how much protein, how often should you hydrate, sleep, how many hours of sleep. This is all a very interactive, scripted curriculum that's gamified, it's fun, it's interactive, there's competition built in. The scope and sequence has been really defined over 25 years, so it's very specific how you do the sequence, and that the content has been modified from both mediation and moderation. We know the moderators, and so we've been able to refine the program. So this is a scripted, easy-to-do program. You get all the bells and whistles with it. There's a team box that have some fun stuff in it. They do get it cut up, do some very active, tangible. They cut up Crisco. They analyze the amount of fat in their favorite snack, and then they got this little thing of Crisco, and they find out how much fat is in their snack. So there's some very, very fun, practical things that go along with this. There's a Flameopoly game. This is a Jeopardy game, Monopoly game that's done. There's the Firefighter Challenge, where they, if they eat 5 servings of fruits and vegetables a day, they climb the ladder and put out the fire. So there's a lot of fun activities. As I said, fun learning activities. Activities are related to diet, exercise, body weight, injury. So it's led by a team member using scripted lesson plans, and then the competition is built in with shifts in other departments. This is an example of what the curriculum looks like. So you can see that it's very easy to follow. This one is protein in foods, where the firefighter is the checkpoint. That's what the team leader reads that day, and they go through, and as I said, they don't have to be familiar even with the program before. Minimal preparation time, 12 one-hour sessions done at the station, and the cost, the materials for all of our research is about $85 per person, one-time cost. A fire helmet is $250. A doctor visit, well, I charge $1,000. Most people charge $100, but no. Doctor visits. This is a third of a doctor visit one-time cost. So this is the way the program looks when they do it. They're sitting around. So we don't want to micromanage and tell them when to do this. We give them the stuff and say approximately once a week you do it. They go on shift. They try to do it. Sometimes they get called. It's a disaster day. They don't get to it. We averaged 10 out of 12 sessions completed in the study, so they got through 90% of all the material and all the curriculum. But, you know, this is real world. You do it at your work. You find, for our police, we did the same thing with my SHIELD study. We're in the 5th year of almost 500 law enforcement personnel. And they find a time to do it. And they find it's at the half-hour briefing in the morning. It's at lunch. It's when they meet at Subway and go through it. So again, we don't micromanage. It's up to the work group, that natural team of when they want to do the program. Firefighters are easy to do. They do it on shift. There's 4 to 7 firefighters per shift. It was easy for them to do the program. So the results are published. I think we have near 20 publications in peer-reviewed journals, and this was the 1-year findings published in JOEM, and we showed a significant improvement in fruits and vegetables. We showed overall well-being. There wasn't a reduction in body weight, but there was no change in body weight as compared to the control group that had an increase in BMI. Amazingly, the reason this worked well in fire department is because they shop, cook, sleep, clean, work together, and so the culture changed. And so 4 years after the intervention, we controlled for age, for retirement. We had a lower body weight among individuals. We had increased VO2 max among individuals. We had improved diet and exercise behaviors 4 years after we left. So the culture changed. They're eating healthier. They're shopping better. Some people did say it was the accountability of having that support of watching each other's back at work. We do have a family component. You go home and you learn how to cook. You continue these healthy habits at home. But really, it was a change in culture. So we think there was this tipping point to where finally, you didn't want to have a bag of M&Ms in front of you. You didn't want to have that drawer of M&Ms. Those cookies were replaced with healthy snacks, and there was a significant culture change that, again, we've published. We didn't set out to reduce injury rates. We set out to improve exercise, nutrition, smoking, alcohol, tobacco, sleep. But when we asked a question on the survey, have you filed, did you get an injury in the last 30 days? Did you file a work comp claim in the last 6 months? In our intervention group, there was a 35% reduction in self-reported injury rates and work comp claims. So I scratched our head and said, what happened during 1999 to 2004? Something pretty significant happened, 9/11. And there was a safety culture change everywhere. A lot of resources were going in. So what I wanted to know was Portland unique, and is this a national trend that injury rates went down during this time? So we examined other Oregon fire departments, similar size, urban, suburban setting, and found that indeed Flame did have a significant reduction in work comp claims and injury rates as compared to similar Oregon-based fire departments. So it just wasn't. In fact, when we looked at that data, there was a significant change just after 1 year in work comp claims and injury rates. The reduction equaled about $1,000 for this $100 investment. So for City of Portland, saved them $1 million with their 678 firefighters. And it was that, at the time, the police chief that said, can you do the same thing for our cops that you did for our firefighters? And that's when we started applying for law enforcement and then finally got funded to do the same thing, to see if we could translate this curriculum, this team-based curriculum, into law enforcement officers. So we had an ROI of 4.6 to 1. That's published in Ahmed. And so we thought, well, what is the difference between corrections officers, firefighters, and police officers? So this is sort of hot off the press data because we have our fire data. I now have my police officer data, which just got published a couple months ago. And now we're doing corrections, and we have some hot off the press corrections data. It's a small study of 85 people, but we can compare the condition, the health risks between fire, police, and corrections. You'd think they'd be pretty similar, right? I mean, corrections officers do work in prisons, but they're law officers. Police may be a little more active, some of them, but police have a lot of desk jockeys that sit around that don't do any work. You have your enforcement group, patrol group, and then you have your SWAT team that are highly trained, but you have a lot of desk jockeys in police. And we've showed you the health risks of fire. So our COs, do they look worse? So I haven't put in, these are the averages. I haven't even put in standard deviations yet. These are 200 males with 60 police officers, 60 firefighters, and 80 corrections officers. They're all male. So look at this. They're all, the top row, they're all about the same age. Years of work, they're all about the same, 12, 13, 14. Their BMI, concerning. A BMI of 25 to 29 or 19 to 25 is optimal. 25 to 29 is overweight, and more than 30 is class 1 obesity. Firefighters, 27. Police officers, 29. These 88 COs, or I'm sorry, 85 COs averaged a BMI of 33 among the males, considered class 1 obesity. Now, one of the criticisms of using height and weight is that it doesn't really assess my bone. I'm just big boned, right? Most firefighters, most police officers, COs, they're just big boned. So BMI doesn't accurately reflect obesity. Okay, well, let's do percent body fat. Let's measure their body fat, and it found that it was 22 for, again, mildly overweight, but 25 for police officers. But again, correctional officers had a significant difference in percent body fat, which is considered obesity among these COs. Waist circumference, anything over 40 is considered too big a waist circumference, no matter if you're 10 foot tall. Goliath, if he had a waist circumference of 40, he may be considered a large central obesity. Anything over 40. So there's 40 for the COs. Glucose, anything over 100 is considered elevated blood sugar and pre-diabetic. So COs, again, have an elevated blood sugar. Anything over 150 for triglycerides is considered elevated triglycerides. The police officers had, a majority had elevated, and the COs had over 200 milligrams per deciliter. Blood pressure, pretty normal for firefighter, pretty normal, mildly elevated for police, but then considered hypertensive, the majority of the mean. Again, this is average. Metabolic syndrome, 19%. In John's study, I believe, John, in BCOPS, you have a healthy cohort. Did you have 16% of your police officers with metabolic syndrome in your first publication, I think? Okay, because, 30%? That makes sense. Sorry, I don't know where I got that. But the average U.S. adult is around 25% metabolic syndrome. That's if you have 3 out of 5 criteria. So if you have 3, high blood pressure, low HDL, high triglycerides, high blood sugar, and elevated waist to hip ratio greater than 0.9 for men, 0.8 for women. If you have 3 out of those 5, you're considered to have metabolic syndrome, which is a totally preventable chronic illness that increases your risk of premature cardiovascular disease. And exercise is the treatment, and certainly weight loss. Totally preventable disease. 19% for the firefighters. Again, normal adult U.S. population, 25. We had 34% metabolic syndrome in our police cohort, and 52% of these correctional officers have metabolic syndrome. So you wonder, kind of scratch your head and go, what's the difference? Police, high PTSD, hypervigilance, high cortisol, shift work, sleep deprived, metabolic syndrome. Why are COs that much higher? And again, what is it about this environment? What is it about their job? As Mitch Morrill said, highest unscheduled absenteeism rates, highest work comp claims in the state of Oregon. Why? We don't know why, but we hope to find out. Lastly, I did a survey in our first year of our pilot-funded study. We looked at, for those of you that work at minimum, medium, and maximum security prisons, when we randomized our stations, our prisons, for our intervention, we wanted to know, was there a difference between are COs working at different prison level security. And this has never been, I just submitted this for publication, but this has not been shown before in the literature, that there is a difference between minimum, medium, and maximum security on weight of our group, on work stress, perceived work stress, on self-reported alcohol intake, concern about alcohol intake, and missed work days. So as prison security level increase, CO stress, unhealthy alcohol use, and missed days increase. So it may be that we do different intervention, or we need to understand at least that there's a difference between COs that work at different levels of prison security. So with that, I'm going to turn it over to Dr. Elliot, who will talk about Ignite and dissemination.
I don't know if it's harder to follow golden retriever puppies or Kerry. So he told you that if we build it, will it work? And the answer is yes. And you're going to work this afternoon with some problems and solutions. So I want to get you thinking your self-efficacy is high, that you can solve some problems and make some inroads. We're all the choir here. We know there's a problem. The issue is how to make some inroads to make it better for COs. Because it's been a criticism of some of the research that came out of NIH and still comes out of NIH. There's all breakthrough and no follow-through. So the idea about dissemination, translation is a big deal now. And I'm going to talk a little bit more about FLAME and what did we do after we made it work. Because even though it worked, people didn't come to us asking for the program. Even though it had a high ROI, it was hard for us to get it out there. And so let me tell you a little bit more about what happened after we showed that it was effective in its initial controlled trials. In 2009, remember the stimulus package, and there was a lot of money available for 2-year grants. One of them was for pathways to translational research. And that's how we studied FLAME. We are really big in acronyms here, and this one was called IGNITE, Investigations to Guide New Insights for Translational Effectiveness. And I don't want you to think I didn't know how to spell FLAME. The original trial was Promoting Healthy Lifestyles, Alternative Models Effects, although the fire chief in Portland did ask us, did say to us when we first went to him, you spelled it wrong. So we were funded to look at a translational model. And when I say translation, everybody talks about it a little bit differently. For us, it's really we think about it as a two-phase process. Adoption, that is getting people to acknowledge and accept a program, to say we're going to do it, and then to implement it and use it, kind of a two-step process. And so we sent materials to all the medium-sized fire departments in Oregon and Washington. We sent them a personalized letter to the chief, to the wellness officer, and to the union head. We sent them a DVD, and I'll show you about that. And we sent them a glossy folder, looked like this, to all the moderately sized fire departments in Oregon and Washington, to 3 people. And that's what that looked like inside the DVD, and a personalized letter to each of the 3 people. We've been particularly interested in videos as a way to promote programs, promotional as training the trainer pieces, and as parts of the intervention, partly because our third partner that Kerry mentioned, son, went to film school, so we had this sort of cheap way to make videos. And let me show you the promotional video for FLAME. And as you watch it, look for 4 key features of a promotional video. Look for testimonials, opinion leaders, some social math, easily understandable science, and then look at what are the key features of the program that I'm going to care about. And so let me show you this video. So it's known that if you send out a mailing with a video, you'll get about 3 times the response of just a letter. And that if people watch a video versus read something, their retention is about double. So there is some reason to make videos. We sent this to 70 departments. We sent the material to 3 key people, all those pieces. How many do you think responded? You think in your mind. got a number 25. So we were pretty happy with that. 45 didn't. Of those 25, we talked to each one an average of 5 times. The range was 1 to 13 phone calls to people, contacts, before they finally made a decision. 19 did agree to participate, and then we picked 12 departments that were the study departments. So those were the adopter departments. And we talked to each of those 3 key decision makers in those 12 departments and matched them to 24 departments of the non-responders to look at what are the features that characterize adoption. Matched them to 24 and 12 and interviewed 100% of the people in the 12, 85% of those key 3 people in the 24. And what we found was, to our surprise, that 9 of the 24, almost a third, never saw the mailer. It never made it to anybody. It went on the desk, it went in the garbage. Somebody else opened it. It was huge just to get through to each of the departments. 3 of 24 already had a program, but really departmental features were a small factor in this. That over half of the people who did say they wanted to do it already had a department, already had a wellness program. So that wasn't a big feature. 3, there was chief turnover, and so there needed to be a willing chief. Not that they made the decision, but they gave permission rather than being proactive. Remember, these are relatively small fire departments, so average number 40 firefighters, average was 70, range was 40 to 140, but kind of like a small business. With a big business, the CEO might have a bigger role than the chief, who really just said whatever. But in 3 departments, there was no chief. There was a turnover, and then things fell through the cracks. The biggest feature that made it happen was having a champion in the department, somebody who picked it up and ran with it, jumped through the hoops, took it to the union, had everybody sign off on it, moved it forward. The opinion leader, really, they weren't always a high-profile individual in the department. So in the terminology of diffusion, sometimes these would be more called, and think about your own role in making change in your own organization, they were called organizational rascals more than change agents or opinion leaders. They were rascals. They got it done. And so it was the chief and champ model that seemed to be, there needed a permissive chief and a go-getter champ that made it happen. And Kerry's daughter was our research assistant and traveled all over the state making those interviews. The second phase is then getting it from implementation to completion. And for the 12 fire departments that adopted the program, we visited them at baseline, had them all complete surveys, launched the program, went back 6 months later, did another set of surveys to look at outcomes. And in those surveys, we looked at what we thought we could get a handle on, things like tailoring, organizational features, leadership features, and then sort of turbulence or scheduling issues. Which of those really made a difference in getting it done in the department? This is where those departments were located all over the Pacific Northwest. That's one of the team, and all those team boxes had to be carted all over the state. So what we did show was that flame did affect the things that we wanted to affect. So the effectiveness of it was confirmed. So we changed BMI, nutrition, quality of life. It was an uncontrolled trial, but in the departments that did it, there was changes in the firefighters in those departments. And what made a difference in getting it in there, the biggest deal was tailoring. So having some ability to modify the program themselves, to change it a little bit, to tweak it like they made it their own program. Really, there was some features, as Kerry mentioned, that we say, you can't change that, you can't change that. We know you need to do that to make it work. But there's lots of features that you can change, so that was critical. That was sort of the biggest feature. Leadership was a feature, and by leadership I mean that there was sort of consistency in the department. I said the chief didn't make that big a difference, but that everybody was sort of aligned and happy in the department did make a difference, that they were kind of a cohesive department. And scheduling issues, so things that could interfere with it. So the turbulence that you can't control, issues that happened where there was something unexpected made a difference. Being able to work around that was a critical feature. Organizational climate, we thought would be a big deal. People have talked about that, and that really didn't have anything to do with it. That really was not a feature. If the other things worked, it happened. So the take-home lessons to be thinking about from this as you think about moving the things you're going to work at over the next few hours forward are, for us, and you heard it earlier, that there's this issue about teams and team-centered, peer-led programs, the sort of bubbling up, the CP new, coming up through the organization, working together, can really change behavior. That changing health and safety behaviors can save costs, and I think that's a done deal. If you move people with behavior change, you will save costs. It's like treating hypertension. We know if you lower blood pressure, people are going to have less morbidity, you're going to save money. If you change people's behavior, you will save money. And if you have enough participation, I'm not sure it was so much that they live together, it's if you have enough participation, you can change the culture. So we think that when we went back and did qualitative on what made the difference for durability, it was that there was a tipping point, that enough people were doing it. So thinking about getting enough penetration on a unit or a work group that it changes the behavior of everybody, that it becomes the culture then and takes on a life of its own. And that seemed to be what happened, why it was perpetuated. So as you think about things, think about dissemination early on. Initially, Kerry showed you the 3 groups, and that was why alternative models. We had sort of the motivational interviewing model, the team-based model. Well, motivational interviewing worked, but it's just so expensive. It was just unrealistic. What were we thinking about with that? It's just too expensive. Yeah, if I have a one-on-one coach with you, I can change your behavior, but I can't afford to do that. Especially it's so hard to track people down when they're busy. So think about, is this something that if I build it, it's going to be able to be moved out there? And that local champions, and again, that's coming up from within and making sure that everybody feels like they own it and that it's theirs and that they can tailor it. And plan dissemination strategies to involve partners early on. So that was really surprising to us, that it was so low that people didn't even see the mailers. And I guess I should have thought of that, because that's why the Humane Society sends me something every other month. Like I need to remove, what. And as much as you can think about the distribution channel, so we've really partnered with the firefighters union and tried to make that the way we can get this out there, to partner with them. And as much as you want to use carrots rather than sticks, there is a little bit of a stick. To get a FEMA grant, you need a behavioral component to a firefighter wellness program, and we have the behavioral program. So thinking about just distribution channels, carrots and sticks, well, how am I going to move this out there? Because it's not going to happen by itself. And then to align the program with the culture. And there's a lot of people here with expertise in what the culture of corrections is. And that's something where you need to align with what their culture is. So for us, in the 10 years since we started Flame, it's really easy to modify a paper and pencil curriculum. It's so easy. We just pull out pages, put them back in the workbook. But now that we know what pieces we need, and firefighting has gone through, everything's on their smartphones, and they do training online now, that we really want to digitalize this and now want to put it online. And that's what we're doing now, try to make this smartphone, web-based, smartphone accessible, but still keep it game, that they learn a curriculum, that there's competition, that there's peer support, and put that into it. But it's really expensive to build stuff online. And so that's the downside of it. Because in the piloting and evolving a program, it's just almost prohibitive to put it online. But we're the place with Flame where we can do that now. And so we did pilot it and learn things from firefighters about, they want it gamified enough, but not too gamified. So when they achieve something, the firefighter douses something, but when we had them play the woo, That was too much. But that's what you got to do. So we're in the process of doing that now. So that's where we are with that. So I want to just give my personal thanks to everybody who's made the effort to be here today. Thank you so much. Really want to give props to Carol and Aviana, who did so much putting this together. And all the worker bees here helping put it together. And now it's going to switch over.
Well, yeah. Just stay up. Any questions about dissemination, translation, about flame, how to translate it into police and corrections?
I have one question about something I haven't heard yet that I've been thinking about a lot, which is proliferation of the knowledge peer to peer. So thinking about it from an epidemiological standpoint, I'm thinking about, so you've infected them with this virus for healthier living. How well do they transmit that to other peers who haven't had the training?
Yeah. So that's a great question. And in the follow-up studies, remember there was 2/3 in the intervention, and it diffused to the non-participants. So although firefighters are generally at a station, if somebody's off work, they travel around and so it did infect each other. It did infect the other people. Yeah. But that's the tipping point piece. If there's enough herd immunity, you can get everybody. Yeah.
So you mentioned you're moving your curriculum to a web-based. How have you thought about how much of a team is needed and how to continue to keep the team while still delivering content online or through smartphones?
Yeah, so that's a great question, and that was one of the pieces that was critical, and so they're going to sign up as a team and compete among each other, and on their on the dashboard, it'll have the pictures of the 4 firefighters on the shift, and there'll be ways that they can look at leaderboards, and they get points, and like a game would be in that way. Yeah, so you're right. That is a critical piece of it. The peer support, what they call positive peer pressure, not although they can be a little bit, brother kind of thing. And in Portland, there is a fair number of women firefighters, about 8%, which is high for most departments. So. And you saw Rose on the video.
Sort of an Oregon question. Is this related to Healthy Team, Healthy You?
Yeah, Healthy Team, Healthy You is based on Flame. I mean, it's another program like that. Yeah, exactly. It's each time with Kerry's Shield, then with Doc, we've gone to school on the previous program, and then said, well, what makes this work? How can we refine it? Healthy Team, Healthy You is another wellness program, occupational wellness program that has both a computer and a paper curriculum piece. Yeah.
I wondered if you had approached or presented this information at like a national conference of firefighter chiefs or whatever, and once you get them, and then you at least have entree into those agencies.
There you go.
So there's close to 300,000 professional career firefighters and another 1 million+ volunteers. And so we have had very close iChief, IACP, and the IFF support of we've been presenting our flame data since 2000 at every conference. So they have been involved in partnering with us, and now they're helping us with our phase 2 STTR to roll it out. They will be a vehicle for dissemination. They don't know if they've never partnered and with a private enterprise to promote a product. This is one area though that they not only are considering, they're going to do because of the impact on wellness and because it's so inexpensive for the bang they get. We compared physician advice, in this, and believe it or not, doctors don't change behavior, unfortunately, us MD, Ahmed docs out there. We don't change behavior. So the model of going to the, primary cares are needed for your annual. We need to utilize that. But work sites, the impetus now is, to me, on the workplace to change behavior. 70% of U.S. adults go to work. We need to change culture at work, and because it's not happening in the doctor's office. And so they all got comprehensive testing. They all got told they had prediabetes, that they were overweight, that they had high blood pressure. Only half had doctors. They don't even utilize their insurance anyway, which is a problem. So, unfortunately, people say, oh, if you just give me your test results, I'll change. If I just know what's wrong, I'll change. Unfortunately, it doesn't happen. So that's why you need a behavior change program, and that's why we are doing what we're doing. So, yeah.
So the ROI that you indicated, that was within the control group that you did the study with?
Exactly. And so that makes the ROI even more compelling, because if you take out comprehensive testing went into that ROI. So if you take out that $550, $600 price tag for comprehensive testing, ROI for the team-based intervention was more like 10 to 1 rather than published 4.5 to 1. And I state that in the publication that we had to include comprehensive testing because we couldn't separate that out. But the team-based program beat MI, beat health coaching by a lot.
And was there a specific arena within the work comp that you saw a decrease in resulting in that ROI?
So back injuries, as you can imagine. So it was severity of injury, and it was time away from work. Okay, great. So again, I think it only gets better this conference. Not to say that Violante wasn't great. He was the best.
Kerry, you have one.
But the panel groups, I think, will spur some awesome discussion and really help us then to formalize where we need to go. Yeah, Ken.
I've got a question. So people forget stuff. It's 12 scripted sessions. At OHSU, you've added on additional years of these. Are you envisioning that as something that's important for this? Or do you think those 12 scripted sessions, developing the teams, the culture will carry them forward?
So what Ken is alerting to is we've developed this program for OHSU employees, and we have 4 years. We have 1.0, 2.0, 3.0, 4.0. We have 4 years that kind of build on each other. In all of our research, we've only done one program, 1 year. And with Flame, it caught on this tipping point. The culture changed. In 4 years, we had improved outcome. In the SHIELD study, I'm preempting here a little bit, we had great changes at 6 months in sleep and stress and alcohol and tobacco. With this 30-minute once-a-week program for 12 weeks, very similar to this, adapted for police culture, we improved sleep quality, sleep quantity, stress, depression, nutrition, fruits and vegetables, significantly dietary fat. But I'm sorry to say we're looking at the 1 year data, and it doesn't look like what held up in fire didn't hold up in police. Now we have 2 year data too to see if that. But your question is, do we need more? And I think it is culture. It's job specific. For fire, it ignited. It took it its own, and they adopted and ran with it. For police, we're doing focus groups now, and Grace and Carol. We have a wonderful college intern who's going out and doing focus groups right now with all of our law enforcement officers and finding some really interesting stuff that we needed the accountability. We changed because of the team. We really liked meeting, but now we're not, and they reverted probably back to their old behavior. So you make a good point on durability. What will it take? I think it's going to take, for police, we need more years. We needed to spread out that program, needed some bridging activities. So we're learning from this. For corrections, we did the same program for corrections, added resiliency meditation, some other unique aspects for corrections. We had good results at 6 months. We'll see what happens, though, later on. Same thing.